वेव फ्रंट ऑप्टिमाइज जब हम करते हैं तो जो मशीन इज बाय डिफॉल्ट वो करती है कि 0.2 एस्फेरिसिटी उसकी आ जाए। दैट 0.2 एस्फेरिसिटी की बेसिस पर हम जितने भी डब्ल्यूएफ को करेंगे हम ये करते हैं कि उसको उसकी एस्फेरिसिटी को चाहते हैं कि 0.2 हो जाए। But our unpublished data at Hashmani of 650 IS in 650 patients, हमारी जो डेटा है उसने शो किया कि this asphericity हमारी जो population है it's not 0.2, it's about mean is about 0.39. So अब हम इसको पब्लिश भी करा रहे हैं और हम देख रहे हैं कि हमारी मशीन में अगर हम ये इंक्लूड करते हैं तो क्या what results will be achieved. Then again the problem was कि यहाँ भी हम बात कर रहे हैं सिर्फ उसकी कॉर्नियल कर्वेचर की, अभी हमने हायर ऑर्डर एब्रेशन की बात नहीं की। देन वी केम अप विद, और इसमें भी आपके एब्रेशन अभी भी आ रहे हैं डब्ल्यूएफओ में, तो देन वी केम विद द कस्टम क्यू। कस्टम क्यू में सिर्फ फर्क इतना है कि डब्ल्यूएफओ में वी आर क्रिएटिंग 0.2 क्यू वैल्यू, इसमें वॉट एवर पेशेंट क्यू वैल्यू इज वी वांट टू मेंटेन दैट क्यू वैल्यू। तो इसमें सिर्फ फर्क इतना है। And what is custom Q? What is Q? Q is the change. Q represents asphericity. What is asphericity? Asphericity is change in curvature of the cornea from center to the periphery. जो ये change हो रहा है that is asphericity. और इस asphericity को आप Q के तौर पर represent करते हैं। तो normal Q value कितनी है patient की? -0.23 to -0.30, and that small -0.23 or -30 will be same in every patient, irrespective of their refractive status, whether he is high myope, is low myope, is hyperope, ये इतनी रहेगी, and that asphericity will produce a positive spherical aberration of 0.30. So these are the meta-analysis. ये meta-analysis की गई, पता custom Q जब हम करते हैं तो how it affects the higher order aberrations and spherical aberrations and all that. So this ये जो जितनी भी आपकी आई उन्होंने बताया कि custom Q takes care of the spherical and cylinder lower order aberration nicely. Both CQ and WF एक ही results हैं दोनों. But as far as higher order aberrations are concerned, as far as Q value is concerned, this is far better. Custom Q वाली CQ जो हम करते हैं उसमें आप बहुत ही अच्छी रिजल्ट अचीव करते हैं as far as this is concerned. As far as higher order aberrations are concerned, they are taken care of better in custom Q, और होना भी चाहिए इसलिए कि आप पेशेंट की Q वैल्यू को मेंटेन कर रहे हैं. Then spherical aberrations भी आपके कम होते हैं in custom Q as compared to your WFO, और कस्टम में spherical aberration कम होनी चाहिए इसलिए कि आपने intermediate zone भी ऐड कर दिया. So अभी तक हम बात करें, we are just talking of lower order aberration. We are not talking about higher order aberration. Then we came up with the fourth this thing, that wavefront guided treatment. Wavefront guided treatment में हम चाह रहे हैं कि we are treating the aberrations that are present in the whole eye from cornea to retina, and all these aberrations we are fixing it on the cornea. So in a way we are damaging the cornea by fixing them on the cornea. So हम उसमें create कर रहे हैं, लेकिन although वैसे हम कम कर रहे हैं. So and these wavefronts, इसमें problem ये है wavefront guided में कि wavefront guided depends upon your pupillary dilatation. जितनी ज़्यादा dilated होगी उतनी ज़्यादा आपका ये काम करेगी. This depends upon the lens accommodation. It depends upon various other factors like lens capacity, corneal elements, retinal elements. So एक वक्त में हम कितने wavefront ले लेंगे? हम एक वक्त में depending upon the pupillary size and depending upon the centroid shape, क्योंकि बार-बार आपकी pupil is moving. So depending upon the pupillary size, not more than 1000, maximum 1500 हम wavefronts ले लेते हैं. तो 1500 wave, और ये they are not reproducible. तो सबसे बड़ा problem इसमें ये है. These are the. So then we came up with another treatment, and that is called contour vision or topo-guided treatment. Topo-guided treatment is far superior than different guided treatment or other treatments. Now, it is taking care of your lower order aberrations also. It is taking care of your higher order aberrations also. And 65% of the patients in this FDA study, they achieve better than 20/20 vision, and there were less night vision problems. Glare has also much less. The depth of focus increased. People used to appreciate it. That we can read nicely now. And why this happened? Because there was no change in Q value. The same thing as in custom Q. There was minimal induction of aberration, and there were correction of higher order aberration. So these led to the better this thing. And nowadays, in most of my cases, I'm doing control. And what it takes is, it is taking the data from with the topolizer, anterior surface of the cornea को वो measure करता है. Anterior surface of the cornea, जैसे मैंने कहा, आपका wavefront guidance में जब आप wavefronts लेते हैं, तो not more than 1,000 or 1,500 wavefronts आप ले सकते हैं. But with this, you can take about 20,000 points on the cornea, and उन 20,000 points के फिर आप एक ablation profile बनाते हैं. So this is far superior than the other one. And it runs under the assumption that creating an anatomically uniform cornea will improve the visual function. दो चीजें इसमें जो you have to be very careful about. Number one, the patient, जब आप किसी readings ले रहे हैं, the optician, the technician who is taking this readings, he must know what he is doing. The reason is कि जिस position पर patient बैठा है, उसी position पर patient theater में लेटना चाहिए. आप patient आपका अगर गर्दन से नीचे है या ऊपर है या टेढ़ी है या वैसी है, तो उससे problem ये होगा कि आप coma induce करेंगे. तो आप induction of उसको avoid करने के लिए the patient position जिस condition में आप ले रहे हैं, exactly उसी condition में patient लेटा होना चाहिए. This is the most important. And there are the different types of doing topo-guided LASIK. One is the manifest effect. जो भी patient का refraction है, उसको हम डालकर and we do it. Or we whatever the topography is giving you the cylinder, हम उन cylinder के हिसाब से वो करें. मतलब या तो हम जो भी मैनिफेस्ट रिफ्रैक्शन चश्मा पहन रहे हैं उस चश्मे के नंबर डाल दें, या जो टोपोग्राफी ने आपको जो रिफ्रैक्शन दिया है, जो आपका सिलेंडर पावर दिया है, वो डाल दें, या मिक्स करके हम करें. और फोर्थ अब ये फोर्थ चीज आ रहा है कि आप वेक्टर बेस्ड एनालिसिस करें. ये हमारी पब्लिश्ड रिजल्ट्स हैं. 94% of the patient achieved 20/20 or better, and we had 50% of 20/16 or better compared with 65%. FDA study में 65% patient achieved better than 20/20. Our study, published study, it achieved 50% patient 20/16 or better. The last thing is that now we are coming up with ray tracing platforms. The research is on, and I think in a year or two, this machine will be out. The best part is, अभी तक क्या करते हैं, जितनी भी वो करते हैं, we understand, or we think that the eye is a bull stand eye with an axial length of 24, corneal keratometry 43 diameter. But जैसे हम जानते हैं कि every patient has got different axial length, every patient has got different keratometry, every patient has got different. So depending upon your manifest refraction, depending upon your keratometry, depending upon your axial length, depending upon your pentagram wavefront analysis and your topography, and plus the biometry that takes into account the axial, the anterior chamber depth and the width of the natural lens, a new profile is created. A new profile is created, and we see a ablation profile is created, and we see that every ray of light is focusing on the macula. If it is not focusing on the macula, then aberrant ray is traced backward again, and it is manipulated until it focuses on the macula. In this way, जो अब जो machines आएंगी, वो machine, whether I do it, you do it, anybody does it. This is robotic surgery. I think this is the first step during robotic surgery. The results are very good. And so with this, I think क्योंकि जब भी हम बात करते हैं तो यही बात होती है कि व्हाट इज सीक्यू, व्हाट इज डब्ल्यूएफ, तो ये मेरा ख्याल है कि मैं जितना भी कर सकता था मैंने कर दिया है. एंड आई थिंक यू मस्ट हैव लर्न something out of my this presentation. So any question, sir?
Thank you, sir, for excellent.
मजर तुम्हें कोई सवाल जरूर होगा, तो बताओ.
तेरे हर सवाल का सवाल ही जवाब हो. तो इसके रिजल्ट्स तो डेफिनेटली आपने बेहतर महसूस किया ना टोपो गाइडेड लेजर के. टोपो गाइडेड लेजर में आपका जो टोपोग्राफर है वो कपल हो जाता है लेजर प्लेटफॉर्म के साथ, या आप किसी और टोपोग्राफर का डेटा भी दे सकते हैं उसको.
किसी और काम नहीं लेते, ले ही नहीं सकते, वो मतलब उसी का है.
उसी का है.
तो एल्कॉन के जो वो है टोपोग्राफर, टोपोलाइजर थ्रू दिस थिंग, थ्रू द मशीन. ठीक है.
तो if there is no question, then we can move to the next presentation. Please. That is small pupil management and cataract surgery.
Next. Now, small pupil, आप सब देखते ही होंगे, small pupil में cataract surgery is a bit difficult. The presentation is not for Queen, तो ये दूसरे बच्चों के लिए है. तो चलिए भाई लगाए, लग गया. चलिए पहली लाइन पढ़ लें आप. इफ यू डोंट वांट टू डू एनी कॉम्प्लिकेशन, या नहीं होनी चाहिए, जो लोग कहते हैं ना हमारी तो कोई कॉम्प्लिकेशन होती ही नहीं है, तो बिल्कुल नहीं होती. इसलिए कि अगर आप नहीं करना चाहते तो डोंट डू सर्जरी. कोई कॉम्प्लिकेशन नहीं. सर्जरी करनी है, कॉम्प्लिकेशन हो. So what are the challenges for surgeon in small pupil? The small pupil's challenges are: one, it limits the size of capsule. You feel very difficult to achieve a nice size of capsule. Number two, it makes the nuclear assembly more difficult, and there is a risk of increasing the iris injury. जो डॉक्टर हमारे मजहरी से सुबह बात हो रही थी कि आप आयरिस की वो देखते थे पहले. एक आपके जो सर्जन थे वो ये कहते थे कि if you want to see what is a good extracapsular, a good extracapsular is one जिसमें pupillary sphincter जो है वो आपका सही काम कर रहा है और आपका जो उसमें आपने कोई डैमेज नहीं किया. एग्जैक्टली इसमें यही होता है कि जब आप ये काम करते हैं तो आपका रिस्क ऑफ इंजरी टू द आइरिस, द स्फिंक्टर इज मच मोर, एंड इट रिड्यूसेस द स्टेबलाइजेशन. पेरिफेरी में जो पीसेस पड़े होते हैं वो आपका परेशानी. You want to do three ways of increasing the visibility. Number one, pharmacological, mechanical और surgical. ठीक है. और omitria is a combination of phenylephrine and ketolite. और ये अगर आप डाल दें तो इससे pupil dilate भी हो जाती है और फिर आपके पास रहती भी dilated है. So this is one which is not available. अब आजकल available है तो I don't know. And the other thing is viscomydriasis. यहाँ पहले Elon 5 और डिस्कोविस्क यूज करते थे कि आप pupil dilate कर देते थे, लेकिन आजकल डिस्कोविस्क भी नहीं मिलती और Elon 5 बहुत पहले. The other thing is we use iris hooks or we can use Malyusin ring. Malyusin ring is very expensive, लेकिन yes, this is a very good tool. The third is mechanical stretching and do sphincterotomies. So my preference is Malyusin ring if the size is 4 millimeter or less, and omidria is the size is 5 to 6 millimeter, and viscomydriasis is the pupil is 5 millimeter. So this is the picture of doing with the iris hooks. And this is चलाएं भाई यहाँ पर. डायरेक्ट है. चलिए This is the malusion ring. ये very good tool और it's very good tool. $200 की एक malusion ring है. It has to be. ये कमाल ये होना चाहिए था कि फोर्थ हुक भी आपका खुद ही आ जाता है उसमें, जो हमने नहीं ले पाए. And then we did it with the hook. This hook is not meant for this. So के लिए हमने एक स्पेशल हुक बनाया है, जो ये आप जो स्ट्रगल कर रहे हैं उस स्ट्रगल की फिर जरूरत नहीं है. डॉक्टर महफूज ने जो हमें सिखाया है कि इंस्ट्रूमेंट बनवा रहे तो हम अब ये बनवा रहे हैं. हाँ नहीं, ये तो हमारा है, ये तो अपना वो जो यूजुअल जो हम यूज करते हैं उसके लिए. This is how you do it, and pupil is dilated, and now we can nice section. Actually, this is a small pupil. आजकल आई एम डूइंग malusion ring नहीं यूज करता, इसलिए कि $200 कौन खर्च करेगा, नंबर 1. नंबर 2 के आयरिस हुक्स डालने में बहुत देर लगती है, तो उतनी मेहनत कौन करे, क्योंकि आप लोग जल्दी वाले सर्जन हैं. आई एम लेजी सर्जन, कितनी मेहनत करके और ये सारा कुछ करना. डॉक्टर शाकिर जो है ये सब कर सकती है, ये इतनी टाइम इसके पास है. हमारे पास टाइम नहीं है भाई. एडजस्टेबल, उन्होंने एक जमाने में एडजस्टेबल स्विचेस में करता था. मुझे एक सवाल पूछना था तुमसे उसके बारे में भी, कि बहुत ज्यादा अगर एंगल हो तो हम लोग उसमें काफी गैप छोड़ देते थे. और हाँ हाँ, तो वो काम करता था उस वक्त, तो अब नहीं पता कि ये आप लोग करते हैं कि नहीं करते. अच्छा, और उसके बाद छोड़ दिया, इसलिए कि सारा काम आप लोगों ने ले लिया. अच्छा, दिस इज हाउ यू डू. और एफएसएस ये है कि जूनियर्स के लिए ये है कि यू एवरीथिंग इज कैन बी अचीव. आप अपना हाथ सेट रखें. यू शुड जल्दी करने की जरूरत नहीं है. यू शुड बी इन द सेंटर एंड ट्राई करें, इन द बैग सारा कुछ करें. और खूबसूरती वही है जो हमें डॉक्टर मजहरी ने बताया कि यू शुड नॉट टेक स्फिंक्टर्स और आयरिस, डोंट इंजर द आयरिस, वरना वो फिर बाद में 10 साल बाद आता है तो पता याद आता है कि वो कुछ हुआ था. यार थोड़ा सा आगे ले लो इसको, क्योंकि ये मेरा खिलौना नहीं है, इसलिए थोड़ा सा तो. अच्छा चल ठीक है, रहने दे. ठीक है, कोई जरूरत नहीं, वो खत्म हो गया.
असल काम तो हो ही गया है ना.
तो मजहरी साहब,
माशाल्लाह.
इसका शेर तो मुझे नहीं आते, याद नहीं रहते. शेर तो मुझे बड़ा पसंद मैं करता हूँ, लेकिन याद नहीं रहते मुझे. कि ये मुझे बड़ा मतलब, आप स्लोली करें, अच्छा काम करें, मतलब काम हो जाता है. तो आपको जरूरत नहीं है कि मेल्यूजन और ये सारे ड्रिंक्स इस्तेमाल करें. इंडिया क्या है? Have you ever tried? नहीं. I have tried it twice at least. और काम करती हो.
ये जो 4 से 5 मिलीमीटर की प्यूपिल है, इसमें तो रिंग और हुक्स तकल्लुफी है. अल्हम्दुलिल्लाह वी आर एबल टू मैनेज इट.
वो तो आपको खुश करने के लिए मैंने ये
तो लेकिन बात प्यूपिल्स बिल्कुल 1 to 2 मिलीमीटर होती हैं,
बिल्कुल.
तो दैट्स वेयर वन शुड टेक दैट. अब उसमें 2 ऑप्शंस होती हैं. अगर आपने इकोनॉमिकल काम करना है तो आप प्यूपिल स्ट्रेचिंग कर सकते हैं, लेकिन प्यूपिल स्ट्रेचिंग करेंगे तो इट विल नेवर कम बैक टू इट्स ओरिजिनल पोजीशन. एक लेकिन ये मैंने देखा है कि ये भी बात ही है, जब आप उतनी छोटी प्यूपिल को रिंग से भी डायलेट करते हैं और सर्जरी के बाद फिर भी वो कभी अपने नॉर्मल प्यूपिल वाले साइज पे वापस तो नहीं आती. तो इसलिए ये रिलेटिव ही है.
स्ट्रेचिंग जो करते हैं उसमें शायद नहीं आती आपसे, लेकिन स्फिंक्टरोटॉमी करते हैं उसमें आप देखें कि वो वापस आ जाती है अपनी साइड उस पर। दिस इज माय एक्सपीरियंस कि आपकी वो वापस अपनी साइड पर आ जाती है।
लेकिन बहरहाल
स्फिंक्टरोटॉमी करके, लेकिन स्फिंक्टरोटॉमी का मतलब ये नहीं है कि आप पूरा आइस काट दिया आपने। यू जस्ट स्फिंक्टरोटॉमी मींस 1 मिलीमीटर ऑफ स्फिंक्टर ओनली।
और मैंने और ये देखा था कि
3 जगह, जो चौथी जगह फिर वही टेढ़ा जाकर करना है, तो 3 जगह काफी है।
और इसमें अक्सर पिपिलरी मेम्ब्रेन होती है, अगर आप उसको रेक्सेस की तरह से जेंटली रेक्सेस की टेक्निक के साथ पील ऑफ कर दें प्यूरी प्यूपल से, तो अक्सर एड्रेनालाइन से प्यूपल डायलेट हो जाती है।
अच्छा, इसमें आप देखिए कि कहीं पर भी हमने ये आयरिस को टच नहीं किया, और जो सेकंड हैंड पीस जो है उसी को ज्यादातर यूज कर रहे हैं। जो गेम है आपका सारे फेको में, टोटल फेको गेम इज द लेफ्ट हैंड गेम।
दैट्स राइट।
आपने उसी को यूज करना है, इससे तो आपने रखना ही है सेंटर में। तो ये आपने एक जगह पर रखे और उसको यूज करें। तो इसको यूज करना, ये जो जूनियर्स हमारे हैं और जो ट्रेनीज हैं जो अपकमिंग, उनको है कि आप अपना ट्राई टू यूज योर लेफ्ट हैंड।
और नॉन डोमिनेंट हैंड कहते हैं हम इसको, एंड आई ऑलवेज प्रमोट दैट द मोर एंड मोर यू ट्रेन योर नॉन डोमिनेंट हैंड, द बेटर एंड द सेफर फेको सर्जन यू बिकम। और इन सारी चीजों में आयरस को बचाने के लिए, कैप्सूल को बचाने के लिए, फार्मेसीज में से लेंस मैटर लेने के लिए, और बिल्कुल एंड पे जाके किसी को प्रोटेक्शन देने में, आपका जो नॉन डोमिनेंट हैंड है, जो जो आप फेको सर्जरी में आगे बढ़ते हैं, इट बिकम्स मोर एंड मोर एक्टिव। और वो बड़ा साइलेंट किस्म का एक वर्कर होता है, जो कि पूरा फैसिलिटेट कर रहा होता है आपके डोमिनेंट हैंड को। तो नॉन डोमिनेंट हैंड को फिर वो पूरा एक सब्जेक्ट है, उसमें आप उससे ब्रश करें, उससे लिखने की कोशिश करें, और छोटे छोटे स्टेप लेके फिर उसको ट्रेन करें। और दूसरी ब्यूटी नॉन डोमिनेंट हैंड आपको ये अता करता है कि आप राइट आई की टेम्पोरल अप्रोच राइट हैंड से और लेफ्ट आई की टेम्पोरल अप्रोच से लेफ्ट हैंड से कर सकते हैं,
आइडियल यही है,
विदाउट चेंजिंग योर पोजीशन।
यू हैव टू बी एम्बीडेक्स्ट्रस। बिल्कुल सही कह रहे हैं आप, ये होना चाहिए ambidextrous. Yes.
Preferably ambidextrous. And the thing is that there are many people who are ambidextrous by nature, but this can be achieved. And I was inspired by Qazi Saab and some other surgeons, and I trained it over 6 months to 1 year, my left hand. And amazingly, if now I have to enter any eye through 12 o'clock position, I feel it very odd. It is such a beauty to operate through supratemporal or temporal approach. It gives so much control on astigmatism and bone morphology. क्योंकि जब आप हमारी डीप सेट आइस में 12 o'clock से जाते हैं, तो आप लाजमन कुछ ना कुछ अनवांटेड डिस्टॉर्शन वुंड में पैदा कर देते हैं।
तो ये डॉक्टर मजहरी जब अभी मैं खड़ा हुआ हूँ, हालांकि सर्जरी इज ऑलमोस्ट डन, बट आई एम स्टैंडिंग हियर टू जस्ट टू शो यू, एंड आई वांट यू टू गेट इंस्पायर्ड कि अभी जो सिमको है उसको छोड़ दें।
अब ऑलमोस्ट हमने छोड़ दिया हुआ है, मैं वही कोएक्सियल और बाइमैनुअल दोनों
मुझे मजा नहीं आता कि मेरा भाई जो है ये अभी तक वो सिमको यूज कर रहा है,
लेकिन अब
मैंने सिमको 20 साल में कभी नहीं यूज किया।
मजदूर सेठों का मुकाबला तो नहीं कर सकता ना।
अब यार ये हमेशा बाय मैनुअल,
मैं दोनों करता हूँ।
मैंने बाय मैनुअल कुछ किए कैसे, लेकिन मुझे मजा नहीं आया। जो मजा इसमें है ना, द रीजन इज कि जब बाय मैनुअल करके आप निकाल लेते हैं, आप इसको उल्टा नहीं कर सकते कि पॉलिश कर सके कैप्सूल को। इसमें मैं पॉलिश करता हूँ, एवरी पेशेंट आई डू पॉलिशिंग, तो वो पॉलिशिंग उसमें नहीं है आप कर सकते, फिर इसके लिए एक अलग इंस्ट्रूमेंट डालो, तो आई डोंट लाइक दैट। तो ये मुझे सबसे अच्छा लगता है कि ये आपका कोएक्सियल जो है इज द बेस्ट वन। बस ये एक मतलब हम गए, इसके बाद वापस मैं नहीं आता। 99% ऑफ माय केसेस आई डू इन वन गो, और उसके बाद आपका ये आई कैमरा के साथ में जाता, कोएक्सियल के साथ। वो एक कोई पूछ रहा था कुछ
जी, मैं फूस साहब का कमेंट है, मुझे सिल के हम इस सिल को यूज नहीं करते, बट सम टाइम ये बात है प्लेट फर्स्ट फेको कर रहे हैं, या फिर वाटर डिसेक्शन से कि प्लेट लाइक वो प्लेट्स होती है, वो फाइनेंशियल सिंबल्स इससे नहीं आज सिल को सीख। ठीक है
यार, आप मेरे पास आइए, मैं आपको सिखा दूंगा। मैं बाय डिसलाइक इट नाउ। आप मतलब अच्छा, दूसरी बात ये कि जैसे मैंने कहा कि लेजी सर्जन कि अब यार ये कौन निकालेगा, वो हम ट्राई करके उससे निकाल ही लेते हैं, ठीक है। लेकिन यस, यू आर वेरी राइट, इन सर्टेन सिचुएशंस यू आर कंपेल्ड टू यूज सिमको। सिमको को डिस्क्रेडिट नहीं कर रहा। सिमको इज अ वेरी गुड इंस्ट्रूमेंट, सिमको से अच्छी कोई चीज नहीं है। बाद में आप फंस जाते हैं, आप सिमको ही यूज करते हैं, लेकिन मोस्ट ऑफ द टाइम यार ये हमारे मजहरी साहब है ना, जैसे जिस लेवल के हैं, उनको चाहिए कि ये यूज करें, यही
उनको चाहिए कि सेठ बन जाए।
ठीक है सर, थैंक यू वेरी मच। मेरी कोई प्रोजेक्ट कंप्लीट है, कोई और सवाल है तो बता दें।
Thank you very much,
थैंक यू
sir.
सर।
I invite Professor Moeen and I request Professor Huma because he has to leave before us. Nangrejo Saab has requested. चलें, Professor Huma Kiani and Professor Huma Kiani Sagar, to be very specific. She is there with her talk.
Sir.
Himani's procedure for secondary implant.
Assalamualaikum. And thank you so much for inviting me to the Hyderabad. The बहुत शुक्रिया. Last but not the least नहीं हूँ मैं. आखिर में मोइन साहब आपके हवाले. Thank you so much, Hyderabad, and I'm humbled to be decorated with the Distinguished Service Award. Much obliged. Thank you so much. So today what we'll be talking about is a continuation of what Hashmani has said and Mazhry साहब ने कहा है कि जितने भी हम पढ़े लिखे हों या जितने भी हम skilled हों या जितने भी हम under training हो, surgery is something that cannot be without complications. So if you want to learn, you have to be prepared for complications. और especially जब आप एक ऐसी साइट पे आ जाते हैं जिसमें आपको टीचिंग और ट्रेनिंग दोनों का नसीब होता है. So उसमें you have to be even stronger and you will be seeing a lot of complications. A few might be done by you, a few might be done by your trainees. So जो कुछ आप करेंगे उसमें आपको the more you see, the more skilled you become and the more you think at how to improving this. So what we're going to talk about today is a one-stage procedure. जिसमें अगर आपके किसी ट्रेनिंग से या हमसे भी कभी किसी वजह से लेंस ड्रॉप कर जाता है, which is patient becomes a patient, या लेंस एक सब प्यूपल से छोटे प्यूपल पे आप कर रहे थे, अगर ये छोटे प्यूपल पे मैं कर रही होती या मेरी ट्रेनिंग कर रही थी तो I would be prepared for the two-stage or a one-stage procedure because most of the time with a lot of handling the posterior capsule does come in your phacoprobe और उसके pressures ना maintain करें, surge आती है, small pupil difficulty and all that. All these will lead to issues of a posterior capsular rent. Now that posterior capsular rent can be a small one that you might be able to handle with the insertion of a lens in a sulcus, and sometimes you don't have that opportunity or the presence of even a small amount of capsule. So we need to look into concept of fixation techniques, and those fixation techniques that have been used in the past also. जब मैं अपने आप को कहती जब मैं बच्ची थी, जब मैं थी when I started with this, there was a concept of anterior chamber IOLs. That is also a fixation technique. You don't have a capsule, you use a anterior chamber and iris for the support. However, it comes with a price. And then there are iris fixated posterior chamber IOLs, also known as PC IOLs. And now, since I think it must be a decade now, उसमें evolutions are in the still fixation intraocular lenses, which we label it as SF IOLs. So what exactly is this SFIOL? It is the still fixation of an intraocular lens, and this is performed when in the bag implantation is not feasible. You don't have a bag, or you don't have you need a bag to put a single piece intraocular lens, or even a multi-piece intraocular lens for proper fixation and proper centration. So if you don't have it, so you don't have a choice, and then comes the fixation techniques. So the types of this SFIOLs that are now that the techniques that are used is the sutured SFIOLs and the sutureless scale fixation intraocular lenses. So the indications, subluxations, dislocation of the lenses, and aphakia with inadequate capsule support, which I've already talked about. And why should we use this? because when you're looking at scale fixation intraocular lens, it provides a better ocular safety profile than ACIOLs or iris fixated, because when your IOL will be on an iris, because of the constant pupillary constriction and dilation, there will be iris chafing, and there will be a lot of pigment dispersion. You will have a lot of uveitis, and that can also, later on, there can be hyphema and even secondary glaucoma. So it is scale fixation IOLs, these are safer for corneal endothelium and iris, and the placement of IOL is in the sulcus. In the sulcus region keeps the IOL closer to its normal anatomical position of the normal crystalline lens. So the techniques, the basic technique is that the optic has to be placed in the posterior chamber, where it should be. Haptics are placed and are taken out of the sclera, and this is 1.5 to 2 millimeter from the limbus. The external landmark being the scleral ciliary sulcus. Haptics are usually located 3 or 9 o'clock positions. However, in case of high myopes or large eyes or Marfan syndrome, it's better that the haptics are taken extracted and moved and fixed in the vertical directions, because the vertical diameter of the cornea is less than that of the horizontal diameter. There are relative conjugations, not absolute. The relative, if there is still thinning, scleritis, uveitis, advanced secondary glaucoma, corneal pathologies, or any pre-existing retinal disorder, they need to be taken care of before you think of using a scale fixation intraocular lens. So now we're going to look at the scale fixation intraocular lenses, and there are sutured ones and the sutureless ones. For the sutured one, you have to make a scleral flap, and that scleral flap has to be sutured. Or if there is presence of glue, which is not present in Pakistan, then you make a flap, and once the haptics are externalized, the scleral flap is glued up, so you don't need any sutures. Looking at the sutureless, you have this one is done. So sutureless intraocular lenses, lots of techniques were started. I remember there was something which we used to have a 25 gauge glass planar ports used, and you would use them and would try to externalize the haptics through them. But that was a lot of problem, because sometimes with the pressure effect, the haptics would break. Mind you, the only problem with this externalizing of the haptics is that you need to have good, strong haptics, because they can break. So the types of intraocular lenses that are here have this issue that they are breakable. So I am not going to talk about the intraocular lenses that can be used, because we can discuss it, but I would not take the name at the moment. So apart from that, then there are the 4 flange interscleral fixation IOLs, in which Proline is used. And I have done 2 double flange intraocular lenses, but because I'm not a pro at the moment, and probably I've never been where these are concerned. So I have a video, but I did not, maybe the day I'm ready, that's the day I'm going to show that. So the 1-stage procedure, I hope I can be able to. So now I'm going to, let's take a content. I know. So we're going to look at a video showing the Yamani technique, combined 1-stage procedure, in which there was a trainee of mine had a dropped cataract lens. The nuclear chunk fell down. There was no posterior capsule. So we thought of what to do. So rather than doing a 2-stage, we went in one go. We took the lens, the opaque cataract nucleus out of the from the vitreous cavity, and combined it with the Yamani technique. So here we go. So this is a 55-year-old male from Lahore. He went an eventful emulsification, which led to drop nucleus. So first thing was to make a 23 gauge or 25 gauge fast planar ports. It's your choice. So we used the 23 gauge ports. We used a 23 gauge cutter, and increasing the vacuum and reducing the cutting rate. It's easy to use the cutter for removing the chunks out. If it's too hard a nucleus, then you will have a problem. Otherwise, if it's like a little bit of chunks with some cortical matter, it's easier to do that. Then, in order to start with the Yamani, you have to use a die and mark the 3 and 9 o'clock positions with the die. Now, there's a problem over here, and that problem that is because the more you learn, you're going to learn, your your sclera has to be absolutely dry. Because if it's not dry, the die is going to spread out. So it's good to tell your mistakes to the juniors also because they learn, we're not picture perfect. So when you started, this was, the die had spread, and now that I do it because I do cornea also, so I know that the wound has to be, the area has to be absolutely dry. The intraocular lens was injected with the leading heptic, which light on the iris, and the trailing heptor was kept outside the paracentesis zone. Now the 27 gauge needle, which is bent initially, is with the dye labels that you've done, you'd use that, you take it inside the vitreous cavity with the bevel facing towards you, and this is the for the leading heptic. So the leading heptic is held with the end gripping forceps. You can use an ILF peeler, preferably it's better to use an ERF peeler if you can. And then just hold the tip of the heptic and insert it into the bevel. Looks easy, it's not. It takes so much time, and you have issues of, constantly you're sweating, and you have an adrenaline pump feeling that, this heptic is going to break. It will be, I mean, it's not something that I'm proud of, but I always have a backup of two lenses with me because I know I might break the heptic anytime. And in one place, I'm taking one, I'm removing the dropped nucleus, I might be taking out the dropped IOL also. So usually in the Yamani technique, the two people are involved. One, a person who's doing, and a very good helper who will be, holding this second lens, a second heptic, and keeping it inside the vitreous cavity. As I'm not that privileged, so I was doing it on my own. So I thought the best thing is to take the trailing heptic out. Once the trailing heptic out, this is 1950 का जो heated bulb है हमारे पास. We use that to heat with the flame and then just heat the tip of the heptic. Now this heptic will now stay in it will not go back into the sclera. So you have like time and maneuver, you can maneuver it. Take the second 30 gauge needle inside the eye, and rather than taking the heptic inside and you're playing in the vitreous cavity, I usually try to bring the bevel of the other the needle out and support or fixate the trailing heptic within the bevel. Now this looks easy. It's like I said, this is the worst one. The leading heptic is always easy to take out because it is facing in such a direction that it is basically you have to pull the heptic out towards you. While in the other one, in the trailing heptic, it is on the other side, the opposite side. And for that, you need a lot of gentle movements because here your heptic can break. And it usually breaks where there is a connection or a joining of the optic and the heptic zone. So once you've heated both the tips of the heptics, you align and you gently put back the heptic into the sclera so that it gets stuck over there. And you check so that the heptic does not erode the conjunctiva, because if it does, the patient is going to have a foreign body situation throughout. So once it's done, take because it was a one-stage surgery, took the infusion port out and removed the vital switches that I had applied for the nuclear matter, which I had taken out initially and followed by the year. That's why I call it a little modified technique of the legend, Mr. Dr. Yamani. Fill it up with subconjunctival injection of antibiotic steroid. And so this is post-operative picture of the same patient, and it's 6/12, and I hope it was of some benefit to the viewers over here. So thank you so much for listening and watching, and have a nice day.
Thank you, Professor Huma, for excellent talk on modified Humani's technique. Now is the turn of Professor Moin Yaqeen, and he is going to talk on managing radial tear in phaco-cataract surgery.
Thank you very much. I'm going to talk about how we manage the radial tear and this is something which everyone comes across. Okay. So this is something which we come across, especially depending on the type of nucleus we are handling or what is the configuration of the eye at that time when we're doing surgery. Especially in patients who are white, mature cataract, you can get that Argentine flag sign, and that can cause the radial tear. So I'm just going to show you basically two short videos. This is typically we're doing white cataract. The anterior chamber is slightly shallow because the nucleus is mature, and we typically do CCC. So I tend to do a small CCT and do a spiraling CCC to make it bigger, because in these patients, I find that whenever you're doing a large size CCC, there's a much more chance of making a radial than not. So you can see I'm making a smaller turn on this side, but as you're going, and I was using methyl cellulose at this time. So if you're using hyaluronic acid, probably you're better off at that time. But usually it doesn't cause you much of problems, but sometimes you do end up. So here you can see it's trying to go out at this level, and now it's gone out. So at that time, sometimes I was whenever it's trying to go out, you need to pull it more towards the inside. Now what to do if you have a radial tear at this moment? One thing is sometimes it might have just gone to the equator and I'm trying to pull it right to the center. It might come back, but it is not coming back. So the next thing you can do is either convert it to an extracapsular cataract extraction, do the relaxing incisions and go about it. The other thing which you can do is I made an incision with the Vannis scissors and started the CCC fresh from this area. So now, so here you can see I've got a radial and it's moving at the equator and it's not coming back. So I tried it again. The reason I'm reforming the AC all the time is because if the AC is shallow, because whenever you're doing CCC, the principle is you're going to do it on a flat surface. If it's a convex surface like a shallow anterior chamber, the CCC is going to run outwards. So you need to make it flat by putting it more viscoelastic inside. So sometime when it's going radial and I think the anterior chamber is collapsing, I use the end gripping forceps or the capsular access forceps. So here I'm able to complete the CCC at least in the inferior part. So whenever you have a radial tear, the number one thing I try to sort of assess is where is the radial? Is it away from the opposite end where the phaco is going to go? Suppose you're going to come at 12 o'clock. If it's at 6 o'clock, that is the most difficult area to do a phaco with a radial tear, because whenever you're going to crack, it's easily going to go outwards. So luckily, this radial tear was in the superior part at 12 o'clock. So there, most of the forces are not very aggressive. So if you are careful, you can sort of go about it and do this. So I tend to go and do it with a vertical chop. So this was a pure vertical chop, do one quadrant, 2 quadrants, and then sort of, because there's a radial tear, it tends to let you bring the nucleus comes into the anterior chamber slightly more easier than it usually comes. Sometimes I tend to do a chop in which I do not rotate the nucleus at all. So I don't use a dialer in that. I use a dialer to chop it, but I don't rotate it. So I I just do it intro at 7 o'clock chop and a 5 o'clock chop and just get the segments out, and then it makes it easier. Here you can see I'm trying to prolapse. The nucleus is pretty bulky, so it's a difficult maneuver at that time. It's trying to prolapse and it's coming out because the CCC is radial and it's giving you space at that time to get that nucleus out. But once it's out, the followability of the phaco machines is pretty good that you can see it comes out so easily in that sense. And there's not much of a nuclear material you have. The next question is, are you going to implant a foldable IOL or are you going to implant sort of a rigid IOL or an IOL which is a multi-piece or a haptic IOL? So I tend to see if the area is far away, it's pretty easy to do this with a foldable IOLs. I planned an Acrisoft IQ lens in this patient, and you tend just to have the haptics on the opposite side. So if it's the radial tier is 12, so you need to have the haptics at the 9 and 3 o'clock position, and it tends to go easily. I tend to get that fear less out of me, because whenever you're doing, I tend to remove silicone oil, do a posterior capsulotomy, and then put an IOL in the bag as well. So that is probably more dangerous than this one, but that is sometimes, but you have to assess how much of a space you have and where you want to go. And whenever you think you don't have enough space, I would tend to deliver the nucleus on the iris, the surface of the iris, and then take it back as easily as it would go. And then whenever you're putting those haptics in, I try not to force them to sort of rotate the haptics too much to produce too much stress. So on the thing. So this is another case in which the phaco has been done. So there's a radial at this is the radial at 9 o'clock. So I've definitely made an incision over on the temporal side to get that cortex out. I'm using Simcoe. Whenever you have a radial, I tend to find that if you use an automated IA, which has got a very high flow, it tends to sort of move the radial out quite a bit. So if I'm having a patient with a radial, I tend to probably have a lower flow and the AC is too much. I would tend to reduce that, and I tend to remove the cortex as limited in the space and not try to pull the cortex too much towards me. So the next question is, can you put an IOL in this patient? Yes, you can still put, and this was another patient, and we were able to put an Acrisoft lens inside in this patient. Similarly, here the haptics will go at 6 o'clock and 12 o'clock, but whenever you're delivering the IOL, that is the most critical time. So I'm trying to deliver it, and with the Acrisoft, you can actually deliver it in one go. Here I'm using that umbilical position of the IOL, and it just goes right in the bag with the upper haptic coming in. But probably if it did not go in this, I sort of push it inside rather than rotate it inside. So that is one way you can do this. This is another one. So done a pretty good case. I don't know why I was trying to make the CCC bigger, but sometimes if you think the CC is smaller and you are fearing a capsular phimosis, you can go inside and enlarge this capsular axis. Usually it's a pretty simple procedure. Here you can see him pulling that CCC and going towards 6 o'clock. And you tend to always watch out for what the anterior chamber depth is, because you never know when it is going. So here you can see it has gone radial. So one thing is to go after it and pull it inside. The other way, the simpler way, I tend to use a scissors. I use the scissors slightly away from it and then turned it over to the other side and completed that CCC. So here you can see, you can go from the other side and complete those CCC. So those are some tricks which you can use. If you have a radial CCC, there are many scenarios and you can come out with different solutions. I think this is of some help to you all. Thank you very much. And thank you, OSP Hyderabad, for organizing such a good conference.
Thank you, Professor Moin. And Pakistan is 122 for 5 in 17 overs. So it all depends how we vote.
So, Dr. Shareef,
Shareef. Our chairman has ordered for some शायरी तो ये हम अवार्ड भी कल मिला ना, लाइफ टाइम अचीवमेंट अवार्ड, तो वो तो लंबा हो गया था बहुत सेशन, वरना मैंने उस वक्त सुनाना था। तो ये प्रोफेसर वासिफ मोहिउद्दीन की वफात को जब 1 या 2 साल गुजरे थे, तो एक दिन मैंने ये आजाद नज़्म उनके लिए लिखी थी। मोहसिन याद आते हैं, मुझे अपने मुरब्बी और मोहसिन याद आते हैं, उस्ताद मन प्रोफेसर वासिफ याद आते हैं। किसी के सर पे जब उसका बुजुर्ग मोहतरम कोई मोहब्बत और शफकत से अपना हाथ रखता है, मुझे अपने मुरब्बी और मोहसिन याद आते हैं, उस्ताद मन प्रोफेसर वासिफ याद आते हैं। किसी का जब बड़ा कोई अखलासो तफक्कुर से किसी उलझन को हल कर दे, अता कोई मशवरा कर दे, मुझे अपने मुरब्बी और मोहसिन याद आते हैं। कोई मकबूल बंदा जब कमाले मेहरबानी से किसी महरूम बेकस को दुआओं से नवाजे, तो मुझे अपने मुरब्बी और मोहसिन याद आते हैं, उस्ताद मन प्रोफेसर वासिफ याद आते हैं। So thank you very much. With this, I request for the chairman for the concluding remarks, please.
Thank you, Dr. Mazhry, for your nice शायरी।
Thank you.
And शायरी के साथ आप जो डॉक्टर वासिफ कादरी साहब के लिए जो बात की, ये वासिफ कादरी वो लाहौर, आई एम इन कराची, हमारा कोई इंटरेक्शन कभी होना भी नहीं था, लेकिन इनके साथ हमारा बड़ा इंटरेक्शन रहा, और अल्लाह इनको जन्नत नसीब करे और इनके दर्जात बुलंद करे। ही इम्प्रेस्ड मी अ लॉट, मतलब उन्होंने जिस तरह से, तो आप लोगों पर कितना इम्प्रेस किया होगा, कोई बात। The conference was very good, well organized, well attended, and galaxy of stars from all over Pakistan were here. So I congratulate the University Hyderabad and all the speakers who participate in this, and I congratulate the whole team. Thank you very much. Thank you.
सर आपके लिए शील्ड है, तो आपके वहां नहीं चले, हम भी हाथ लगा लेते हैं शील्ड को आपकी। चलें प्लीज। I request all the available speakers to come on the stage and receive their shields.
The shield is for Professor Hashmani. किसकी है बेटा? Dr. Shareef Hashmani साहब. Professor Hashmani.
So with this, the session as well as the conference comes to an end, and every good thing has to come to an end.
Thank you very much. माशाल्लाह जितने भी सेशन हुए आप लोगों का बहुत बहुत शुक्रिया। अभी इंशाल्लाह लंच के लिए जो सारे तशरीफ लाए, लंच इज रेडी नाउ।